Hi, folks. It's Mark Weissman and Tamara John at Children's National, and we're pleased to host our 5th learning session as part of our Regional Quality Improvement Learning Collaborative on improving childhood asthma care in practice. And today we actually have a great panel presentation put together on environmental management of asthma. And so with that, I'm going to introduce Molly Savitz, who's part of our Impact DC team here at Children's National. Molly, take it.
Thanks, Mark, and welcome everybody. We do have a busy program today, but I think a very interesting one. We hope you'll enjoy. I've called this Breathing Easier. I think we've initially called it Breathing Easy, but I think to be realistic, we're going to talk about breathing easier and looking at environmental issues in the management, their role in asthma, and how to effectively assess and counsel families about the environmental exposures they encounter. On our panel today is Dr. Jerry Paulson. Some of you may know he wears many hats. Notably, he's the director of the Mid-Atlantic Center for Children's Health and the Environment and the medical director for National Global Affairs for the Child Health Advocacy Institute here at Children's. And he has many years of primary care practice as well, so he will know where you all are coming from with this work. Joy Purcell is here with us today from the Children's Law Center. Kate Scott and also Margaret Schnitzer, we don't have a picture of, are joining us by phone from Baltimore. They run a home visitation program for environmental issues, children with poorly controlled asthma in Baltimore City. And we'd like to acknowledge the EPA especially for helping support this program. The EPA also supports a lot of the work of the Mid-Atlantic Center that Dr. Paulson runs. None of our presenters have anything to disclose, nor does the EPA. And as usual, you can get up to 1 CME credit for this presentation. So what we're hoping will happen today is that you all will learn a little bit more about the importance of environmental exposures in asthma morbidity, that you'll have some better sense of how to select or create a screening tool for use in your practices, and that you'll have some more information on providing families with focused, tailored counseling for their particular exposures. And also that you'll also have an understanding of what some of the community resources are for patients that have particularly challenging environmental issues. I wanted to share with you that about just 29 of you completed our pre-survey that we sent out earlier today and last week. So thank you for that. And a full, almost 90% of you reported that you have at least moderate confidence in assessing environmental exposures, which is great. Slightly under that, we're at least moderately comfortable with the counseling aspect of this work. And most of those were in the sort of moderately confident category. So you're all doing great, and the data that we have on the project so far shows that most of the practices are doing quite well and improving with respect to evaluating environmental exposures and counseling about them, but there's still work to be done, and some practices are still looking for the best ways to do that. So, of course, every practice is different, and what works for your practice may not work for another practice. We will share some of our favorite tools with you, but we also hope that you will share with us. And the next practice call, I think, is next Thursday. There'll be an opportunity for you all to share with each other what's worked in your practices and looking at environmental screening and counseling tools that are easy to integrate into practice would be a great thing to share. So here's our outline today. Briefly, we'll talk about why environment matters so much, give you a little background to underscore why we're devoting a whole session to this. Talk about screening, talk about counseling, and then have some words from our legal counsel and from our environmental in-home assessors about what to do when counseling in the office is not quite enough, and we'll share some resources with you. So with that, I'll introduce Dr. Paulson, and he can tell you a little bit more about the Mid-Atlantic Center and about why screening for the environmental exposures is so important.
Thank you, Molly. Good afternoon, everybody. This image that you see right now is a single-family home, and while some of our patients do live in single-family homes, Not all do, but the information presented on this image, I think, is relevant in a lot of settings, whether they're in multifamily dwellings, single-family homes, whether the house has a basement or is built on a slab or whatever. But there are a lot of things that influence indoor air quality. First and foremost, the indoor air is not separated from the outdoor air, and so if they live in an area where there may be a lot of outdoor air pollution, that is going to get inside. Cooking chemicals, cleaning chemicals, exhaust from anything that burns in the house, whether it's tobacco, whether it's burning on a stove, natural gas, or food, burning in a fireplace, burning in the furnace. All of these things get into the house. And finally, there are chemicals that can come in from the ground, not so much influencing asthma per se, but radon is certainly a significant issue in its own right. Cleaning chemicals, and then chemicals that people bring in on their clothes, for example, from the dry cleaner, are all issues that we need to ask about and think about in trying to manage kids with asthma. Also, this image is of a home, but kids clearly spend a lot of time in schools, and while the buildings are different, many of the issues that influence indoor air quality in the home also influence indoor air quality at school, and we need to be cognizant of what's going on in the building where the kids go to school. So between school and homes, kids spend a tremendous amount of time indoors, more time actually than they spend outdoors. And for some kids, between early child education or preschool care and after school care, these kids can spend up to 90% of their kids inside. And of course, for many kids, most of that indoor time, or the biggest proportion of that indoor time, is their bedroom, so we need to think about specifically what's going on there. With the exception of laws pertaining to environmental tobacco smoke, there really are no laws that regulate indoor air quality. We have a lot of laws that try and regulate outdoor air quality, but nothing that does indoor air quality except for environmental tobacco smoke. Now, there is a lot of scientific data that cockroach antigen, house dust mite antigen, mouse antigen, and pet dander can exacerbate asthma for children who are sensitized to those danders. And so knowing about the presence of these triggers in the home may be key to improving the child's asthma management. And unfortunately, as we all know, in spite of the broad national efforts to prevent tobacco smoke or to get people who do smoke to stop, many people still do, and this can exacerbate asthma in those kids who react to some of the chemicals in tobacco smoke. Even smoking in other parts of a building where it's a multifamily dwelling may get into the child's specific residence, and so environmental tobacco smoke can be an issue even when nobody in the family is smoking in the actual residence of the child. So this is a scene of Atlanta on a bad air day and a scene of Atlanta on a good air day. And we have good air and bad air days here in the greater Washington area, up in Baltimore, and throughout the region that the Children's Network covers. And the sources of outdoor air pollution include cars and trucks, power plants. Even here in the District of Columbia, the Mid-Atlantic Center was just asked about a child who lives near Capitol Hill, where there is a power plant that serves the Capitol buildings themselves, and an issue with asthma in that child. Depending upon where you are in our region, there may or may not be some industry that influences air quality, maybe not so much here in downtown D.C. where we don't have a lot of heavy industry, but there are clearly other parts of the region where there is industry. There are incinerators dotted throughout the area that the network where you all practice, and then individual buildings and factories can influence the air quality near a home or near a school, and if you don't ask about it, you may not find out about it. This case that we were recently asked to consult on, the mom recognized that there was something different in the smoke coming from the power plant on days when her child had an exacerbation of her asthma. Now, there are a lot of things you can do individually about mold or about cockroaches or about rodents. And on the one hand, you do need to tailor your advice to the family depending on the specific problems that they have in their domicile. But on the other hand, it's important to recognize that many times these problems do not occur in isolation. So if there's a moisture problem that has contributed to mold, the moisture can also be a source of what the cockroaches need for their growth as well. And so many times the interventions need to be multifaceted. And there is some, unfortunately, relatively limited scientific evidence that shows that if you target the roaches or the mice or the mold in homes where kids are sensitized, you can decrease the severity of their asthma.
Thanks, Jerry. So, we really hope that by better addressing these issues, ultimately children will be obviously better managed, have lower morbidity, and will reduce their dependence on medication as well, which is a goal, as we know, because of concerns that families have and I think practitioners have as well about children on chronic medication. So in talking about screening now, because I know this is an issue of great interest to some of you, we've introduced you to some tools briefly in the past, and we'd like to delve in a little bit more to some of the tools that are out there, a few, some of our favorites, but there are others, and what works for us may need to be adapted for your individual settings. But in general, we feel that screening for environmental exposures should happen in a comprehensive manner, at least annually. And this could be, probably would best occur at a planned visit or at a well visit at a time that you're having a family perhaps complete a more comprehensive questionnaire updating the history in general. Perhaps this could be done at the same time as an asthma control test is done. We've talked about building that into practice. Having a family initially completed in a waiting area or having a medical assistant or nursing staff complete it with a family that can then be reviewed with you, with the clinician during the encounter. You may be able to build these into electronic health records. Many of these tools are available to do that. We encourage you to at least do a targeted review of known exposures during follow-up visits or urgent visits because these environmental exposures are going to play a role almost certainly in the ongoing control of your child's asthma. During periods of poor control, really is probably a good time to maybe drill down a little bit more. It may be obvious what the environmental issues are. It's springtime is coming, the pollen counts are high, and there's your reason that the asthma control is troubled. But sometimes it may require a little more probing. We've had children, for example, that spend time with a non-custodial parent, and every time they visit that parent, come back with an exacerbation, and sometimes a little deeper questioning is required to find out what's going on there. I've had cases where the parent was using a lot of cologne, and the child would sleep in the bed with that visiting parent and always come back with an exacerbation, or children that spend time with a cousin or grandparent where there are pets in the home, for example. So here's a tool that we have shown you before, but here it is in full. This is the form that's developed by the National Environmental Education Foundation, NEEF, and they're a great resource for this tool, but also for other information, deeper information on environmental issues related to asthma and environmental education around children in general. But this is a 25-question form. It's meant to be done with by the clinician, by our clinical staff. Some parents would be able to fill it out themselves, but it is meant to be at least reviewed by the clinical staff. There are 25 yes and no questions and then a general question about concerns. And it's pretty comprehensive with respect to a variety of exposures that could affect asthma. And I'm showing you here just a little snapshot from it. So this questionnaire will ask, for example, about the worst time of day and location, season, changes in climate, stuffed animals in the bedroom, carpeting, et cetera, and a variety of other issues. And it's fairly well done, and as a comprehensive screening tool, we think it's one of the best ones that there is. I want to encourage you to follow the lead of this form in the sense that it's important to ask about all the indoor environments where children spend time, as Dr. Paulson mentioned, the schools, but as well grandparents' houses, sports facilities, et cetera. There are a lot of other places that kids spend outside of their main home where they could be affected. This is also a snapshot from the form that we use in Impact DC, and what we've done is have cross-referenced our questioning with the NEEF questionnaire so that we're getting to all the same issues, but we may ask the questions in our own way, and so it's a little briefer than you'll see in a full-page questionnaire. And this is part of our intake form we've just integrated into our intake. We ask, for example, about roaches, but we also ask about water bugs. We ask about the heat source, and we ask specifically about fireplaces, wood-burning stoves, because we found that asking a question one way sometimes doesn't get the information you want. For example, people may be reluctant to say that they have roaches or might be using the word water bug for roaches or cockroaches. Mold, mildew smell, people might not see mold, but they might notice water damage or mildew smells, which can be markers for mold. Another suggestion for a way that you could, what you could use to quickly assess is use your asthma action plan. You're all using an asthma action plan in some form, and I think no matter which state or municipality you're from, there is an area on the action plan to note triggers. Now, this one is a quick checkbox. Quick checkboxes, you'll be filling this out anyway, so as you're doing that with your family, this can be your documentation that you've assessed. So another form we came across recently, which is now one of my new favorites, and was shared by Dr. Shields Harris from the ARC, and they are using there, comes from the South Bronx Asthma Partnership. And this is a terrific way to integrate screening with low literacy family that can use the pictures to circle or mark areas of concern that they've noticed, and also a way of assessing their understanding of what exposures in the environment might trigger asthma. So you'll see there's a picture with a variety of potential triggers in what looks like a child's bedroom and a checklist. I'd encourage you to always review this with families. You never want to let this be the only contact you have is to hand a form, of course, and that you'll review this to make sure everything has been understood, that you've probed a little bit more about some questions that were checked, areas that were checked. Also note that there's a difference, of course, between triggers and exposures, and many people may not realize that something that they are exposed to in the environment could be a trigger of the asthma, and mold is a good example of that. All right, we'd like to spend a little time now talking about what to do when you identify potential triggers and exposures. So Dr. Paulson.
Great, thanks. So I apologize perhaps for this image at lunchtime, but you know, we do need to talk about cockroaches, and they need what we need to live. They need a reasonable temperature, they need a little bit of water, and they need some source of food. And you can often find cockroach antigen in the kitchen, But one of the places in the home where people have found higher levels of cockroach antigen is actually around the TV, because people eat while they watch. And if people are eating in their bedrooms or in other rooms of the house, then too you may have cockroach antigen there. The best way to control cockroaches is not through spraying pesticides. That can be associated with its own problems, both as it relates to the neurotoxicity of the pesticides and how the spray in the air can be a trigger for asthma. So really what you have to do to limit cockroaches is what's called integrated pest management, limit their access to foods by keeping food in sealed containers, cleaning up spilled food, and then getting at their source of water. I recognize that this can be tremendously difficult for families who live in multifamily housing, because even if they do the appropriate things in their unit in the multifamily housing, their next door neighbors may not be doing the appropriate thing, and it can mean that their problems don't go away. House dust mites, again, not too hot, not too cold, just the right amount of humidity and some source of food, which in the case of house dust mites are the dead skin cells that flake off from our bodies. Hence, they live in mattresses, upholstered furniture, and carpets. By keeping the humidity below 50%, you can limit the number of house dust mites. You can't get rid of them entirely. There's obviously a balance that one has to achieve. You don't want it to be so dry in the house that the kids are getting a bloody nose, or that people are getting electric shocks when they kiss each other. But on the other hand, keeping the humidity low is important. This can be a particular issue in schools, where if they turn the air conditioning off over the summer because there are no kids there as a way of saving energy, they may then get very high humidity, particularly in the Baltimore, Washington area, over the summer, and they may get problems not only with house dust mites growing, but a marked growth of mold over that time. Limiting the carpeting, so in that image of the bedroom that you saw a few slides back, there was some carpet, and by removing that carpeting and removing some of the stuffed animals, you can remove places where the dust mites live. And then while you want to keep the humidity low, damp mopping the floor is a way of removing the antigen from the settled dust on the floor. Molds need water, and they can use essentially any source of carbon for their food source. So wallpaper, wood, cardboard, and once the area has become damp for more than about 48 hours, you really can't clean it. You need to remove the mold-infested materials. So in this image that you see here underneath a sink, you can't really clean that mold off of that particle board in the back. And just painting over the mold will also not resolve the problem. That particle board needs to be removed, and that's the only way that you can get rid of the mold. Mold can be cleaned from non-porous surfaces like the surface of a commode or a stainless steel refrigerator or something like that, but carpet, wallboard, fabric, etc., all needs to be replaced if it's been damp for more than about 48 hours. One case we were asked to consult on, a mom living in a trailer had a roof leak. The kids' bedroom started to show visible mold, and the child's asthma got worse. She moved to another trailer and didn't understand why, while the asthma got better, it hadn't gotten as good as it should. It hadn't the control hadn't gotten back to where it was before the mold started to grow. And when I asked her, she had brought the children's clothes and stuffed toys and bedding to the new trailer. And I said to her, you know, I understand this is a financial hardship, but the only way you can manage this problem is to get that moldy material out of the new trailer. And when I checked with them again, the asthma control had improved upon getting rid of that, the bedclothes and stuffed animals and things like that. So again, running a dehumidifier in the house, again, particularly here in DC, Baltimore, we've got the Anacostia, we've got the Potomac, we've got the Chesapeake Bay. It's humidity city to some extent all year long. And if there's a leak from a roof, from a pipe, from the apartment above, that's got to be cleared up very quickly or mold is going to start to grow. Pets. For those of you who've managed kids with asthma, and I know that's everybody on this call, you know that talking about pets can be a big issue. Families often don't want to get rid of pets in spite of the fact, even when you've got a documented skin test reaction to the pets. Rodents are often a different story, but some people keep some forms of rodents as pets. And while birds are supposed to be hypoallergenic, dust mites can live in their feathers, and so kids can have problems even with birds. And so at home, it's clearly a negotiated personal choice, but I think schools should definitely be no pet zones, and all schools should have no pets. The problem there is that animal danders stick to our clothes, and so even in no pet schools, kids and teachers and staff can bring the danders with them to school.
And Gary, I wanted to ask about removing a pet from the home and how long it takes for the dander to dissipate. My understanding from speaking with allergists is that this can be 6 months or more before, even with cleaning, that the dander will dissipate enough to make a difference clinically.
I think that's correct, and that's important not only from the standpoint of a family's got a pet and they agree to get rid of it, and then you're assessing a lack of improvement or they're thinking that things should get better instantaneously, and that's not going to happen. But another place where this can be an issue is a family moves into a new building, a new apartment or a new home, and they may not be aware that the previous resident, particularly if it's a rental situation, had a pet. And all of a sudden the asthma control deteriorates and there's no, quote, obvious reason, unquote, but there may very well be residual pet danders. HEPA vacuuming, wet mopping are all things that do help to some limited extent, but these antigens just stick to surfaces very tenaciously, and they will biodegrade over time, but it does take a while. You've heard the statement that environmental tobacco smoke contains over 3,000 toxins, and this little graphic here just gives you some sense of what some of those toxins are. There is some limited evidence that even a physician who is not caring for the person who is smoking, or a nurse practitioner, or even one of your medical assistants in the office, when a medical professional says to an individual who smokes, you should quit, that does have some impact and increases the probability that they will stop smoking. The 1-800-QUIT-NOW is a resource, or smokefree.gov is a resource that pediatricians can refer adults to. Unfortunately, here in the District of Columbia itself, this particular resource is not available. The QUIT-NOW is not available right now, but the smokefree.gov certainly is.
And I have a little update on that, that it's true that the DC program is not available. So what's happening now is that they are referring, if somebody from a DC area code calls that number, the person will be referred to the National Cancer Institute Assist line, which is another option. They can provide phone counseling, but they don't have as much in the way of resources for families. So it is phone service, but not as robust a service as the QUIT line is in other municipalities in the state.
And I do want to emphasize this QUIT line, when it works well, it's not just, you know, somebody doing a little bit of a spiel. This is real counseling that's individualized to the person that they're talking to. So this is more of a resource than we might generally think about, you know, 800 toll-free numbers. So I want to encourage people to put this in their toolbox and use it when it's indicated. So this is that graphic that Molly showed you before, the trigger-free bedroom. So the rug is off the floor, the animal is out of the area, all the toys as dust catchers are cleaned up and in the box. The mold, which was in the upper left-hand corner of the room, if you noticed it, is gone, and the cat's replaced with a goldfish. So that's just some of the things that you can do, and it's the room with the most return for investment is going to be the bedroom.
And this is an example of a form that could be used as a teaching tool, obviously, and it contains a checkbox for the particular issues that are related to your family's exposures or triggers, and it sort of puts everything in one place. So it's a simple and very user-friendly form. We'll show you a couple of others that get a little bit more specific to specific exposures or triggers.
So this is an image of one of the forms that Impact DC uses, and you are by now, I hope, well aware of the impactdc.org website. You are free to download this form and use it as it fits in your practice. And besides the furry pets and birds, there are a number of other useful forms on the Impact DC website. This is a patient information sheet that's available from the NEAF website or the National Institute of Environmental Health Sciences website, and again is downloadable, reproducible, not under copyright, so you can make whatever use it fits for your particular practice.
Some of these forms will work better for families with lower literacy. Some people may want a little more detailed information, and so there's some really great resources out there, and these are just, again, a few of our favorites.
So getting to springtime, as we are, I hope, after snowpocalypse didn't happen yesterday, thankfully. Kids are going to be outside, and they bring particularly pollens inside with them on their skin, on their hair, and on their clothes. So when they change into their bedclothes, that gets rid of some of the pollens, but washing their face and hands, and in particular, washing their hair prior to bedtime so that then the pollen doesn't rub off on the pillow and then their nose is in that pillow all night long, can be beneficial for kids who are highly sensitized to the pollens that are going to be out over the next couple of weeks. Intranasal steroids can be useful as an adjunct in the management of asthma, even though this is steroids applied to the nasal mucous membrane and not to the lung. If you listen to the radio or television news every day, you hear about air quality indexes, and this is something that you can teach your patients to key into. The air quality index for the next day is usually announced in the late afternoon or early evening, and this gives some sense for sensitive groups as to how safe it might be for them to go outside. And particularly for the code orange, red, or purple days that we not infrequently have in this Baltimore, Washington area in the summer, these are days when kids who react to ambient air pollutants may best be getting their exercise in the inside than the outside. Another place for people to get even more detailed information about outdoor air pollution and pollens in particular is airnow.gov. And again, for anybody with web access on a smartphone or an internet connected computer can log on to this, and patients, older patients with asthma or families of kids who have asthma should be taught to use these resources.
So now you have a patient that you've done great counseling with around their exposures, their identified exposures, and still their control is forced. They're still ending up in the emergency room. And upon discussion with this family, it's clear that there is more going on in the home than they can deal with on their own. So I'd like to turn the call over to Kate Scott and Margaret Schnitzer in Baltimore to share with us how they have dealt with some of these really intractable environmental issues for children with asthma, and what they've learned that primary care providers can share with their patients in practice.
Hi, this is Margaret Schnitzer from the Baltimore City Health Department. I want to talk to you a little bit about the services that we provide in the community for kids who have asthma. So I'm sorry, I'm trying to move the slide. It's not happening. All right. So the focus of our program is two-pronged. We do both comprehensive reduction of home environmental triggers as well as asthma medical case management. We use community health workers in these efforts, understanding from our perspective that a well-trained community health worker can really kind of connect to the families that we serve and make a difference in their lives. Our target population are children with moderate to severe asthma, and we figure out that by using a screening tool over the phone to kind of to assess their symptomology. Most of our kids attend Baltimore City Public Schools, and they are all between the ages of 2 and 18. Okay. The goals for our community asthma program is to decrease asthma morbidity and symptom days, as well as decreasing the use of emergency rooms and decrease hospitalizations. At the same time, what we're trying to do is close the loop between providers and families by increasing the provider knowledge of what's exactly happening in the home, what the environment is, and how kids are taking their medication, and helping the provider communicate better with families. We are also trying to increase the family's understanding of the different components of asthma management, both how better to manage their asthma kind of medically following the doctor's asthma action plan, and also what they can do in their home to increase their asthma management, asthma management environmentally. So the intervention consists of 3 home visits that take place over about 4 months. In general, we do 1 home visit a month with families, and then 6 months after the final home visit, we conduct a follow-up phone call with families. One of the main things that we do is to help the family identify the asthma triggers in the home. And the way we do that is by actually walking through the home with the families to look at what might be triggering their child's asthma. So we walk through the home using the PHA, the Pediatric Environmental Health Assessment, and we look at things like, are there roaches in the home? Are there mice in the home? is anybody in the home smoking? Are there rugs? And also looking at broader things in addition to asthma, some other safety issues. Once we do that, or actually as we're doing that, our home visitors use that as a means of providing asthma education as they go. So if they're walking through the home and they see mold in the bathroom, it's an opportunity for them to say, this is an asthma trigger and here's how you can manage that. A lot of what Dr. Paulson said is information that we give out to our families, teaching families how to reduce their roach population. We talk to families certainly about smoking, both about smoking cessation as well as smoking harm reduction. So if families aren't willing to quit, we do talk to them about how to make it a little bit better for their family member with asthma by smoking outside using kind of we call it a smoking jacket that they can take out and leave outside. So try to take it step by step with families and wherever they are ready to have us intervene. We also provide supplies to decrease those asthma triggers. So for families, we provide mattress encasements and pillow covers so that children aren't as exposed to dust mites. We provide green cleaning supplies. We provide some IPM supplies, things like mouse traps if the family needs it, and provide them instruction on how to use those and what's the most effective way of decreasing the pest population in their home. For a very small percentage of our families, we also supply HEPA-Vax if we feel that that's something that will decrease the triggers in the house. Finally, after every visit, the home visitor completes what we call an encounter form, and it's really kind of a list of what we've found in the house, both environmentally as well as what we've observed in terms of medication adherence and medication technique. And we provide that information back to the provider, back to the medical provider via fax, so the medical provider can have a much better idea of what's happening in the home and hopefully get a better understanding of what the family is being challenged with in terms of asthma management. We also do encourage providers to give us asthma action plans so that we can help the family understand what it means and then work with them a little bit better.
So hi everyone, this is Kate, and I'm going to talk a little bit about the social determinants of health, because we realize that has a huge effect on our efforts to reduce asthma triggers. And one thing that Dr. Paulson said that we have found in our own program is the individual behaviors in Baltimore were very similar. Many families used raid as a means to manage their cockroach infestations. Many families believe that everyone they know has pests. That could be mice or roaches. And then individually, we found that many families have competing concerns. So when a child is having an asthma exacerbation, that becomes their high-level top priority. But then once that child is feeling better, then what happens is that something else takes its place. It's either the gas and electric bill, or it could be a multitude of things. From a social environment standpoint, we found that families were unfamiliar with IPM, and IPM is integrative pest management. It's what we've been talking about today. That's basically removing food, water, and shelter from mice and roaches. That also means using techniques other than sprays or, as they say, bombs that people put off in a home, because they just don't work as well as baits, gels, and traps. And then also in Baltimore, it's an inner city population, and there's many stressors, not just from a hectic lifestyle. The physical environment is probably very similar to DC. We have row homes. The majority of them, for the families we serve, are in homes older than 1950. They're mostly renters, and what we find then is that the homes aren't in the best condition. So if you've got a leaky roof, You're going to have problems with mold. You're going to have sources of water for roaches and mice. Also, roaches and mice are going to travel between the row homes. And then the other thing we found is that health services in general do not address environmental asthma triggers. And so that's why we were so glad to be invited to this webinar, because we think it's wonderful to try to incorporate the environmental asthma management component to care. So what did we do? So as Margaret said, we have community health workers, and they do one-on-one teaching. So they work with families and they meet them where they're at. So for example, if a family's biggest issue at the time of that home visit is a BG&E bill, then they're equipped with how to handle that BG&E bill crisis. If they're worried about eviction, they will deal with that. Otherwise, they're not going to get anywhere with the family. So then once that's dealt with, they'll talk about what they found in their home environmental assessment. So that can include the IPM teaching and pest supplies, the green cleaning supplies that Margaret talked about. And those green cleaning supplies, what I like that we use here is we use baking soda and vinegar. We use Murphy's oil soap, things that you can find in the grocery store that are very cheap and don't cost a lot. And then we give them recipes and along with like little spray bottles where they can make their own supplies. The mattress and pillow encasements that Margaret mentioned. And then we work with landlords and tenants. And so because we realize that families are often in a tough situation with their landlords, and so they need some help navigating through that, especially if they need help with some of the upkeep in their home. And then finally, that encounter form, which I think is one of the most important things that we do, because we send that back to the medical provider. Not only does it include the environmental triggers, but it includes a basic symptomology, daytime, nighttime, rescue medication use, slowing down of play in the last 2 weeks. It also includes coordination of care, which is your ER and hospitalization since the last home visit. So it's a little snapshot. And there's many times when I was here at the health department that I'd get a call back from a physician who said, I had no idea they had a cat. I didn't know they had a roach infestation. And that then influences the care management that they provide at the clinic level. So what have we learned through this partnership and program is that our best results came when we were linked with a medical home. And I'll give you an example. The Breathmobile really bought into our program. And so what would happen is that we would get a referral from the Breathmobile, and then the nurse practitioner would follow up saying, have you had a home visit? You know, how is that working for you? And so there was a loop of communication between the health department and the medical home. And I think once the family realizes that we're really there to help them and that the medical provider understands how important is what we do and vice versa, that it just seems to serve the family better. And then just to stress for the providers that are on the phone that maybe don't have access to a home visiting program, that it is really appropriate and helpful to ask about pests in the home and their smoking habits. Just like was mentioned before, you know, just mentioning that, talking about it can have an effect on people's behavior. And then also, let's say you don't have an asthma home visiting program in your area, but you could partner with your local health department because they'll have handouts and things available, or hopefully to address environmental issues. Or maybe from this webinar you can take some of the things you've learned and use those in your clinic. And I think that all for our part. Yeah.
Thank you so much. I think Baltimore has a great track record of these home visitation programs and has studied it and found it to be very effective in reducing asthma morbidity. And unfortunately, these kind of programs are not available everywhere, but I did want to mention that DC does have a Healthy Homes program run by the DDOE, and I won't spend a lot of time on it, but to let you know that it is available. It's only been in running for about a year, but they are actively accepting referrals. So if you have a family that's in DC that has, with a child with poorly controlled asthma, you'll have the information on later in this presentation, and we'll also post the referral form on the QI team space so you can refer families to this program. Includes a home visit, hazards evaluation, reports to landlords, education for the family, and case management for up to a year. And they really try to coordinate because they are part of the government with other agencies. Unfortunately, there's no programs that we're aware of in Prince George's County, Montgomery County, or Virginia, but please share if you are aware of a program through your local health department or another agency that can do in-home assessments. Please share that with our group and with each other. And TJ can post that to the team space as well. I'm going to turn it over for the next few minutes, and we want to be sure we leave a little time for questions and answers to Joy Purcell from the Children's Law Center, and I'm trying to advance the slides. Here we go, who will talk with us about these families that we've done our darndest to work with in the office. Maybe we've even written letters to landlords or to other agencies, and then there continue to be issues. I will say that our program has had some very good experience simply with writing a letter to a landlord about the effect of home exposures on the child's asthma, and have been able to affect some real changes in the home. But there are occasions when that's not enough, and Joy's here to tell us about what else we can do.
Thank you. Yes, I am an attorney with the Children's Law Center. We're a civil legal services organization in DC, and we provide free legal services to DC families in a variety of matters. I'm actually in the medical legal partnership, which is called Healthy Together, and we have a partnership with Children's National Medical Center. We are staffed out of 4 different locations in DC. I'm actually on site here at Children's National 3 days a week. We're also partnered with the Mary Center. And how the medical legal partnership works, just to give you a very brief overview, we work with doctors, nurses, social workers, all the different providers to kind of help educate them on legal issues that might be coming up in their patients' lives, and then help them flag issues to then refer to us if there's a case that, maybe this is beyond just the medical care that the child's providing and there's actually a legal issue that's impacting the child's health. So our 3 practice areas are education or special education, housing conditions, which we're going to talk a little bit about today, and access to health care, which can be a variety of things, some of which are listed there. So the housing conditions cases that we see, and this is actually kind of how medical legal partnerships got started in the very beginning, about 15 years ago or so. The idea is that, there's a child with asthma, he's receiving medication, parents have been counseled about what they need to do to reduce triggers, but the child's just still having asthma attacks, it's not getting any better. And so the idea is to bring a lawyer in when maybe there are issues, housing code violations that are actually aggravating or causing the exacerbated asthma. So the types of conditions that we frequently see, the most common conditions that are referred to us: pest and vermin infestations, and that can run the gamut: cockroaches, mice, as we talked about, bed bugs even, mold, cracked or peeling paint, which can obviously have other far-reaching implications, leaks, sewage overflow. These are all housing code violations. Under the law, tenants are entitled to safe and habitable housing, and a landlord who fails to remedy a housing code violation within a reasonable period of time is actually violating the law. So what can your patients do just on their own before possibly resorting to a lawyer? We refer to kind of these as like the self-advocacy steps that they can do to help themselves or possibly help their attorney if it does go in that direction later on. First of all, we always counsel all of our clients and urge you to counsel your patients to document any existing housing code violations. So that can be photographs, that can be a written notice to the landlord if somebody's actually written a letter stating, I have mice, we need to get this taken care of. Date that, keep a copy so that they can use that as proof that they provided notice to the landlord later on. A tenant can also request a formal inspection by the agency responsible for conducting building and housing inspections. That's going to vary by jurisdiction or state. In DC, it's actually the Department of Consumer and Regulatory Affairs, or in some properties, the DC Housing Authority. The family can also provide information to their landlord about the impact of the housing code violations. This can be useful for a variety of reasons. One, so that perhaps the landlord takes it more seriously. They understand that this child is going to the emergency room on a weekly basis because of the asthma attacks. Also, if there is a legal case later on, the amount of impact that it has on the family's life can actually be one of the considerations that a judge might look at. How can you all help? There's a variety of ways, and when we provide trainings to our providers, we kind of help you guys figure out the ways that you can flag issues and then ultimately follow up and provide support to the families. So first of all, ask families what's going on. Help them identify the housing conditions. And I know that all the presenters have kind of talked about some of the different questionnaires or checklists that might be useful. That's actually would be really useful in a legal case as well. So, asking parents if they have any concerns about the conditions of their home or what's going on. Also, just a little bit of legal education. You don't have to be a lawyer to do this, but just kind of educating families about their right to a safe or habitable housing. You'd be surprised, unfortunately, for a lot of our families, they just feel like this is kind of what they're used to. Everybody in their apartment building has pets, they might say. But that's actually a housing code violation. So they may be entitled to appropriate extermination. So make sure that they know about that and are ready to kind of advocate for themselves. Remind them to document whatever conditions may exist and then actually reach out to their landlord to request the repairs. And then also, you guys can really support families, as Molly said, with providing them with some tools to use in their own advocacy. That can be a letter that's written by you that just kind of gives a quick diagnosis, how that diagnosis can be exacerbated by existing conditions in the house, either through infestations or molds. And then the tenant can provide that to their landlord as, some additional support to try and get the repairs completed. So if that does not get the job done, what should a family do? So I know we have a number of different providers here from different states, and the legal options are going to vary by state in terms of how a tenant can approach these issues. In D.C., we actually have a pretty progressive model. The Housing Conditions Calendar, which is part of the civil calendar in D.C. Superior Court, was created a couple years ago, and it actually allows tenants to file affirmatively against their landlord to enforce the housing code. Prior to the existence of this calendar, tenants were really not able to get into court unless they withheld rent, notified their landlord that they were going to do this, and the landlord actually tried to take legal action against the tenant. Now with this, the tenant can actually file affirmatively, which is good. It protects the family from necessarily having to be evicted, and it puts them kind of in a position as the person filing affirmatively. Tenants can also choose not to do that, and they can actually follow the formal legal procedures to notify their tenants, put money in escrow, and actually withhold rent. Unfortunately, in Maryland and Virginia, families do not have access to a housing conditions calendar, so they may actually need to take some kind of more complicated issues, such as withholding rent. So let's say that you have talked with a family and you think that they may actually need to be referred to a legal provider for assistance. Everything that you've done and that they've done has been unsuccessful in getting the conditions repaired. What can they expect? If your patients ask just any information that you have and just to give you an overview of what to expect. Most times when a family is referred to a lawyer, they're going to complete an intake interview to determine what the issues are and what legal options they might have. Families should definitely be prepared to provide any documents that would support their case. So, the photographs, for example, that they might have taken, any written notices to or from their landlords. And then the tenant and the attorney can determine what the best options are for that family to secure habitable housing. Keep in mind, and this is something that we always tell our families to keep in mind, that unfortunately securing a transfer to a different housing, whether that may be a different apartment or a different property, can be very difficult. And frequently tenants may only be entitled to obtain repairs to their current housing, so the attorney would advise them of that and what their options are. How can you guys support them in this if families do end up requiring legal assistance? You can, again, help families by providing tools to use in their legal case. That can be either through an affidavit regarding the care that you've provided to the child, the fact that they have this diagnosis or that they've been to the hospital so many times, any medical records that you might have showing the diagnosis of asthma, and then information, again, about how common conditions can actually exacerbate the existing health conditions. And finally, let's say if the family does end up in court, you can even provide testimony, which can be very helpful and compelling to judges who may not actually know how these issues can impact a child's health.
Thanks, terrific. And we're running out of time here, so if anybody has questions for Joy Purcell, for Dr. Paulson, or for Kate Scott or Barbara Schnister from Baltimore, please start chatting them in now. And I will just sum up by reminding everyone that we are welcoming your input on tools that have worked in your practices that you can share. And next week, again, on the Project Leaders Call, there'll be an opportunity to share those. We are also going to post the resources that we've mentioned today on the QI team space. And in summary, we want to keep this real for you, and what we'd like you to take away from this, because it's been a lot of information, is that a screening tool is useful to use while patients are waiting. Be sure to review it with them. And there are a variety available. Pick what works best for your population, or invent your own, and making sure that at least once a year you're touching on all the important issues, and more so when a child is having poor control. Also, be sure to always ask about all the places the child spends time. Always ask about smoke exposure. Try to keep things non-judgmental. Families can be very embarrassed sometimes about their living conditions, and may be reluctant to open up to you about their behaviors or living conditions as well. Keep educational handouts on hand. You may use something very simple, or you might have some more detailed information for families that want more. Also, resource lists for the community resources available in your area for easy referral. And of course, always document what you do, because you do so much. And if it's not there, even in a simple form, it may be overlooked that it was covered. So, the rest of the slides essentially are resources for you to look at later, including the EPA's publications website has terrific resources. The Mass General Hospital Cease Tobacco program has great resources. They're the inventors of the Ask, Assist, Refer program on how to assist families with tobacco cessation. Great tools for practices. And legal support referrals in the various jurisdictions that we're addressing today. The Healthy Homes programs that we've mentioned, and the Mid-Atlantic Center that Dr. Paulson runs. I know we did have one question, at least for Dr. Paulson, about the air quality control charts and where those are available from.
Those air quality control charts are available from government websites, airnow.gov, or the EPA website. If you have trouble finding them, you can certainly just get in touch with me at the phone number there, and I will send them to you. Let me make one other comment. As a practicing primary care doc, I have an extremely low threshold for writing letters about mold. You know, a lot of my patients will bring me a photo on their cell phone, and if they've got problems with their kids' asthma and a photo on their cell phone, I write them a letter and send, you know, as part of what I'm doing for my management. And I will provide some draft letters that you can customize to be put on the website, on your common website that you use for resources.
I'll add that in the letters that we provide from Impact DC, we usually cite sections of housing code, and we're not lawyers and we don't sign the letters as lawyers, but we find that just noting that for the landlords is a little extra push. It also helps to have a very motivated family. We recently had a family that had no heat and no hot water, in addition to other exposures in the home. And between a letter that we wrote, strongly worded letter, and on about the effects on health, and the family's motivation, we're able to get those problems addressed quite readily. So that was very encouraging. Another question we have from Dr. Ogunsanya is about the role of passive smoking on kids with asthma. Just a comment on that?
Certainly. Passive smoking, or third-hand smoke, as it's sometimes called, I think that's what you're referring to, certainly does contribute irritants to the air. And it was mentioned, the folks in Baltimore talked about people going outside and smoking and having a coat that then they leave outside, so that coat does not bring particulates and volatile organic compounds back into the home that can be irritants. I think we have all, from time to time, walked into an exam room where we know there's been nobody smoking in the exam room, but the third-hand smoke is so dense on somebody's clothes in that exam room or their hair that we start to gag. And, you know, I'm sure you've had the same experience that I've had, is walking in that room and saying, well, who's the smoker here? And they say, how do you know somebody smokes here? And they don't smell it anymore. So keeping this clothing out of the environment, not having people smoke in cars, because that, you know, basically coops up all this air pollution in a room on wheels, and then you bring the kid into the room on wheels and they're going to have problems. So these are all important issues to keep in mind.
Joy, I had just a question for you about the availability of your services through Children's Law Center. Are there services available to children that are not in primary care at children's clinics or practices?
Yes, so the majority of our clients and our referrals do come from primary care providers at the various children's clinics around the city. However, we always welcome referrals from other providers as well. We take referrals all the time from Impact DC, where there may be, you know, the primary care provider may not actually be a children's person. So we're obviously happy to talk with the family, and if we're not able to help, we can provide them referrals to the right place.
Okay, thank you. One more question. We're given several legal centers in the DC area for our families. Too confusing. Which is the best place to start? Would you say to start with the Children's Law Center?
I mean, if it's a Virginia family, you can also refer them to us. We would probably end up having to refer them out to a Virginia provider. So again, you can definitely refer them to CLC, or, I mean, we had the jurisdiction. So if you know it's a Virginia family and you want to just give them that number, you could try giving them that number.
And same for Maryland, probably the Legal Aid Bureau in Maryland is probably a good place for them to start if their family lives in Maryland.
Yeah.
Okay. Well, it looks like we are out of questions and out of time, so I will thank everyone for their participation and attention. And Mark, any final words from you? No, nothing from Mark. So,
yeah, well, I just want to thank our panelists for a great job covering a lot of ground from inside the exam rooms in our clinical practices all the way out to our community and region. So great work, and my thanks to all of you.
Thanks, Mark, and we'll see you all in the next call.